morning. My presentation is actually really interesting for many soccer teams. All soccer is the main exercise that is practiced over all the world because it's easy to play. Everybody can play it. Very popular. But business or football is not the same. They involve many things that affect to all the sportsmen related to practice. So, okay. This is a real case in which I think every year dies two soccer players playing at the field, because I try to explain. They are athletics and they competitive on athletic situation. But the exercise that they practice is not exactly the same exercise that practice one athlete. It's an exercise that is an exact period of time of 45 and another 45 minutes on they practice everything related to athletics. So the guidelines, the table of contents I try to show is the team's exercise characteristics, sudden death, sudden cardiac death, COVID issues, very popular, so too. COVID guidelines, clinical assessment and conclusions. So this is another example. The one player dying during a match. This is another one. This is an example of athleticism. Another soccer player died. And this is the only statistic that has been shown during many years. From 1995 to 2001, 61 cases. From 11 years to 65 years. The sport most frequently involved were cycling, 21, soccer, 13, and gymnastics, 5. Athletic cardiac issues, popular exercise practice leads many people to dedicate themselves to running and fitness practice. Most of them has normal cardiac activity for their common life, but neither of them, except professional athletes, gets a good cardiac period evaluation. That is a key point to keep them alive and healthy. Cardiac exercise efforts may lead to undesirable side effects because it's not the same. The power needed to develop the normal activity than the power needed to exercise activity. So, elite soccer exercise characteristic. Soccer is characteristic by a series of acyclic sections that develop during a match or a competitive trials in the form of high-intensity running and activity. Consideration. Aerobic endurance is an essential issue to get the maximum effort oral the maximum for optimal performance. Not all people are able to get professional endurance. Many personal conditions lack the behaviors due to their clinical cardiac situation. The highest, being a professional athlete, requires super fit factors: speed, balance, flexibility, and strength, key components of all-around fitness. One new from CBA shows that World Cup soccer players are the top of the game. Within this endurance contest, numerous explosive bursts of activity are required, including jumping, kicking, tackling, turning, sprinting, charging pace, and sustaining forceful contraction to maintain balance and control of the ball against defensive pressure. The rate of anaerobic energy turnover is high during a period of a game. During a soccer game, a sprint bout occurs approximately every 90 seconds. It's lasting an average of 2 to 4 seconds. Sprinting constitutes 1 to 11% of the total distance covered during a match, corresponding to from 0.5 to 3% of effective play time. The average work intensity measures as percent of maximal heart rate during a 90-minute soccer match. An irregular maximum exercise is close to the lactated threshold, or 18 to 19% of frequency max. Is defined as the highest exercise intensity, which where the product and removal of lactate are equal. They may partly explained by the 150 to 250 brief intense action atop athlete performance during a game. During a 90-minute game, elite level players run about 10 kilometers as an average. Typical distance covered by an outfield player during a match is 10 to 13 kilometers, with the midfield players being superior to players in the other position. So, the key point of this is aerobical, anaerobical. What's the difference? The lactate production. So, lactate increase progressively to be high during exercise activity until reach the threshold period. So, glucose on the first part, glucagon on the second part. The heart suffers because it's not really adapted to be in an anaerobical situation. So the main issues is that in anaerobical situation, heart leads to get more size, and coronary are not able to supply blood to that high size. And then all the specific electrical part gets failed. So, athleticism, football, many people try to practice, but they are not good reviewed because most of them, as soccer players, has some congenital abnormalities, has some metabolic abnormalities, has a different expression of the ECG, and that could be reached a risk situation with the high risk situation. So, sudden cardiac death in young competitive soccer is a tragic event that has been brought to public attention. In the past few decades, the incidence of sudden cardiac death is reported to be 1.2 per 100,000 per year, with athletes at 2.5 times highest risk. Soccer players over 35 experience sudden cardiac death, most commonly due to atherosclerotic coronary disease and malignant events. Due to soccer players nowadays keeps playing older than on previous years before, the cardiovascular risk on these players is rising. Soccer player characteristics with high cardiovascular demand and isotonic work puts athletes at greatest risk for sudden cardiac death related to cardiovascular issues. So all this, the prior mention I made. So data collected from user studies shown hypertrophic cardiomyopathy, that was the most common cause, followed by congenital coronary affecting anomalies, myocarditis, pericarditis, arrhythmogenic right ventricular cardiomyopathy, ion channel pathways as long QT and balance syndrome. Are pure electrical disease. Sudden cardiac death could be induced by a trauma blow to the chest, commotio cordis. Also, the incidence of sudden cardiac death is known to be greater in males than females, because football, even this women's football, is mainly practiced by men. So, on 2012, an international group of experts in sport cardiology and sport medicine convened in Seattle to define contemporary standards for ECG interpretation in athletes. The majority of disorders associated with increased risk of sudden cardiac death, such cardiomyopathies and primary electrical disease, are suggested by a normal finding present on a 12-lead ECG. The interpretation of an athletic ECG is the ability to accurately differentiate the findings suggestive of a potentially lethal cardiovascular disorder from benign physiological adaptation occurring as the result of regular intensive training. So those are the main issues that could be found in a normal athlete and a normal soccer players. In Spain, it's very common that local towns has their own soccer team, and they are very young people that needs to be reviewed because they comes with their mothers to say, my son wants to practice soccer. So the trainer told me that has to be reviewed. And that is the beginning of the problem. So these are the main issues that could be found on this kind of examinations. Okay. Some words about hypertrophic cardiomyopathy. This is a normal finding in many people because there's an autologous dominance heritage in many families. So many times we found an increase of the volume of the heart in persons that are practicing athleticism or soccer. But it's very important to differentiate the normal athletic heart than the hypertrophic myocardiopathy, because even are not able to be good differentiated. We have to reach the blood analysis and look for any difference about family procedures. The suspicion of this diagnostic is suggested by cardiac symptoms with the findings of murmur of abnormal electrocardiogram. Abnormal ECG patterns are present in the majority of those patients. The diagnosis is confirmed by 2D echocardiogram or cardiovascular resonance. In findings show an absolute increase of the left ventricular wall thickness to 21 to 21 millimeters on average, which also can be associated with mild right ventricular hypertrophy. The cause of death in those high-intensity players is due to subendocardial ischemia that leads to ventricular fibrillation and other tachyarrhythmias. Congenital coronary artery anomalies is the second most common cause of sudden cardiac death in athletes under 34. The most common is the Valsalva malformation. Patients usually present with cardiac symptoms include exertional syncope and chest pain. The diagnosis is commonly confirmed by transthoracic and echocardiography in children and supplementary by scintigraphy and CT. Timely diagnosis of this disease is critical because athletes must be restricted from competitive activity to prevent sudden cardiac death. That was the problem I mentioned. And CCA are surgically corrected. The arrhythmogenic right ventricular cardiomyopathy is not a very common issue, but in Spain was the cause of the soccer player in Sevilla, because this player was designed to shoot, and then his collapse, and the autopsy revealed arrhythmogenic right ventricular cardiomyopathy. All players, all professional players, has their own medical in every team. But this doctor mainly is focused on orthopathic procedures, but not in heart. In heart, the heart is not considered many times, but the heart is the main issue to consider for these players, because they are not able to play if the heart is not to work, is not good. And many of them needs a continuous review. So the presence of T-wave inversion from V1 to V3 or premature ventricular complexes or left branch block morphology on 12-lead CCG are the main issues during cardiovascular screening. So, in my experience, this is the most common finding when I study those patients. I'm not patients, those players. So many of them has mitral prolapse. So many times I ask myself, what is the egg or the chicken? What's first? Because they are very athletic sporter, but They were with prolapse, with a mitral valve prolapse from the birth, or it's a cure. So it's a very difficult question, because there's some studies that shows that when a very strong exercise is practiced, the mitral valve trends to prolapse. So, other question, trends to prolapse because there is a congenital malformation of the connective tissue or not? That's a key point. But it's the main finding on those kind of patients. So very important soccer players at now in the main teams over the world, I have the opportunity to review them, has mitral valve prolapse. Commotion cordis is typical, a typical ball pump, and those cause a malign arrhythm, and then the soccer could collapse or death. The Brugada syndrome was found in one soccer player in my team that was absolutely with no symptom, but shows this pattern. And this is very important to assess well this kind of problem, because every elite player is the head of very business situation, and the retire of this kind of player costs a very lot of money to many clubs. And there's causes without a known cause. In these studies, there's 24 cases with no diagnosis. Maybe channel disorders found in family members of individuals who experience sudden cardiac death. More research is needed on the efficacy of screening the relatives of these individuals and prevention. Toxicological findings, cardiac effects of steroids and other medication may predispose to sudden cardiac death. And so many teams, because they are reviewed very deeply to buy drugs, are using caffeine and energized drinks that has at least 6 to 10 more amount of caffeine than the normal coffee. So coffee is a high power tachycardisant in person that has a substrate of be promoted to arrhythms, the cardiac issues, the caffeine effect could be lethal. And this is quiz. 4 years, athlete, marathon runner, also halterophilia, healthy life, no cardiological symptom, reviewed due a period prolonged interval on routine ECG. No abnormalities on blood sample test, color Doppler echocardiography, normal pattern, except septal thickness 10.7 millimeters. Holter promedium range 55, max 112, minimum 45 at night. That shows atrioventricular first block during most recording time. Frequent episodes of atrial ventricular second block MAVIT1 and one episode of ear interval of 3.6 seconds. Treadmill test shows 14 METs, ST increase with SS's progression, no VP alteration, and no ischemic signs. What to do? What to do? But it's a real problem. Some guidelines said nothing. Wait for. Other guidelines said we have to study his family. Other guidelines said it has to be submitted to electrophysiology study. Other guidelines said this has to be submitted to a percutaneous examination. So it's difficult to manage those patients because they are practicing, they are marathon runner, halterophilics, has a critical GSO, but how we have to proceed? Saying no exercise, stop, let's see. Or other is a key point because this affects to many people. The current guidelines for pre-participation screening have not reached a consensus. It's a pity. In 2004 and 2005, the European Society of Cardiology and Internal Olympic Committee published notably similar guidelines which contrasted the American guidelines. The main difference was the addition of a 12-lead ECG to the history and physical examination. This decision has been based on the study done by Corrado that showed a significantly decreased incidence of sudden cardiac death due to hypertrophic cardiomyopathy in the Italian population. However, the low specific of ECG as a screening tool in a athletic population is a major disadvantage for its use. So the nowadays situation is that UEFA is the European Association for Soccer, for professional soccer, are mandatory to perform to every professional soccer player an ECG and blood test and an echocardiography. Nowadays, in Spain, the federation, they asked to any football player, even young football player, sorry, because in Spain is football, young soccer players, has to be submitted to an ECG and an echocardiogram. And there's a lot of abnormal findings on that simple examination, because never one sportive family considered that could have any problem that affects those children to practice soccer. It's very, very important. What about COVID? Wow, COVID. Spain, according with the EU countries, decided to force all people to keep at home during 4 months. All soccer matches were stopped. All players were confined, as a population was. After confinement, the soccer players playing was authorized progressively with public limitation. They play soccer with no people seeing them. So was, but only if the team keeps at least 12 players to play without any COVID infection diagnosed. There's a problem in many teams that there's a problem with many teams because at the same time they have all the team with COVID and can play. But even if they have one or two with COVID, they treat to play with other players, but the federation said no. All players with COVID infection diagnosed were confined during 1 month. All personal contact was limited to 1 to 5 meters, and all people was obliged to use face mask, even the soccer players, except on direct play. Total players on first Spanish league affected were 74. Atletico de Madrid class has 4 players affected, with an important consequence. That was the trainer also has COVID. Cholo. El Cholo. All players were submitted to a periodical test procedures, even as necessary, and after agenda stops and holidays. So if they has to play the local league, they has to perform 1 test. If they stop to go to Europa League, they has to perform new procedures. And they every day were perform procedures. So current guidelines, the FIFA Medical Assessment and Research Center developed and implemented a comprehensive pre-competition medical assessment tailored specifically to this population. The cardiovascular screening included personal and family history, physical examination, ECG, exercise ECG, and echo. The results showed that cardiovascular pre-participation screenings in international elite soccer teams seems appropriate, and that while ECG and echocardiography with further saturation could be useful, exercise stress testing remained questionable. Moreover, it was probably believed that the participation screening distressed soccer players due to the fear of being removed from competition. However, a study done with Norwegian professional soccer players found that the players felt more confident after screening and would recommend it to other players. Well, nowadays, there's one soccer team in Holland that has one player with a defibrillator playing. So it's a very curious situation. Further studies on sudden cardiac death in athletes and other sport involves more detailed reporting of sudden cardiac death because an associated sport. Other studies report a statistically significant QT prolongation of rest in professional athletes when compared to age-matched controls. Future studies need to be directed towards identifying further cardiac risk factors. My experience from last 2 years has been to evaluate the elite soccer players permanently on the first team on Atletico de Madrid soccer club. All players has been submitted to a planned full periodical annual review regarding their physical status. According to the cardiovascular evaluation, physical exam, 12 leads ECG strips, transthoracic echocardiogram, and treadmill exercise test is annually performed. But the main extra hospital review is performed every 6 months on all players, different from annual hospital review. This evaluation is performed at usual playing condition directly on the team installation, because The most close approach to players leads to a more efficacy evaluation of the players. This review includes, after training physical exam, 12 left long recorded ECG, a transthoracic echocardiography. Those are the device I use. This is a wireless echocardiograph, very useful on these situations. The characteristics of these players are from 90 to 36 years, the mean 24 years old. All of them submitted to at least one prior full medical exam and signing club contract. Most of them provides previous medical exams from their previous soccer clubs. But I remember one player that came to a very soccer country that sent us an ECG that shows the Brugada syndrome, and they said that was normal. Genetic testing for players' ability. Intensive and systematic training increased the risk of sudden cardiac death in genetically positive athletes. Recommended are mandatory in those with family history of sudden cardiac death. Genetically positive athletes, although from the clinical point of view were asymptomatic. Sportsmen with history of syncope, although echo, ECG, and exercise tests are normal. All soccer players from face male and female teams are submitted to a genetic testing procedure to assess and prevent risk factors. And those are my findings on those players. A total of 38 registries were abnormal. 52% related to ECG or echo abnormalities. Incompleted right branch block were obtained on 12 players. Incompleted RBB plus mitral prolapse were on 10 players. Biventricular growth on 1 player. Incomplete left branch block plus left ventricular hypertrophy on 1 player. Long PR plus inversion of T-wave from V3 to V5 on 1 player. Long PR on 3 players. Long PA with PCB beats on 2 players. Paroxysmal atrial fibrillation on 1 player. Brugada syndrome on 1 player. From 2013 to 2022, a total of 73 registries were obtained from individual cardiac assessment on principal soccer players. The players nowadays belongs mainly to Atletico de Madrid, but several of them are in different main European teams. All of them were submitted to physical examination, 12 ECG with long recording capabilities and echocardiogram. No soccer player spontaneously reported any cardiovascular anomaly. Well, it's the same. Echocardiogram findings. This is an example of mitral prolapse in this kind of patient. Conclusion. Athleticism practice with high cardiovascular demand and isotonic works put athletes at greatest risk for sudden cardiac death. Sudden cardiac death in soccer is most commonly due to congenital and or acquired cardiovascular disease. Due to soccer nowadays are older than on previous years before, the cardiovascular risk is risen. An intensive, permanent, and normalized care is mandatory to premature identification of cardiac abnormalities, adequate triage of abnormalities regarding player safety, full follow-up of athletes with a cardiac problem pre-diagnosis, quick solution to cardiac problems on elite soccer players.